Active range of motion of the shoulder is done while the patient mimics the clinician. The clinician is assessing pain, ability of the patient to perform, assessing the amount of motion the patient has actively and willingly. Active range of motions test is to see if the patient has pain or complication with activation of the muscle. This can indicate or rule out a muscular injury. Passive range of motion is done with the patient lying supine with their arm off the table, completely relaxed. The clinician assesses the patient's ability to relax while assessing and feels the ranges of motion. Passive range of motion allows for the abnormalities to be felt by the clinician within the joint, as well as see if the patient's willingness to allow the clinician to perform the test. If the patient doesn't allow, there is some discomfort. This can indicate neurological or soft tissue damage, as well as a blockage within the joint. Resistive range of motion is done with the clinician applying resistance through range of motion that the patient goes through. The patient starts at the beginning of the range of motion while the clinician encourages movement through the full range of motion. Resistive range of motion allows the clinician to feel the strength of the patient's muscles when activated against a force. It allows for a clinician to see muscle weaknesses and possible pain associated with. The clinician has the patient abduct their arm while they run their hand across the correct locations for C4, C5, C6, C7, C8, and T1, making sure the patient isn't looking or paying attention, but more so what the patient feels. Performing dermatomes allows the clinician to assess the patient's neurological distribution or disturbance. The clinician is looking for the patient to feel the same sensation on both sides, and a difference means presence of nerve distribution is affected. Myotomes test the presence of a muscle to contract. The patient is placed in a position in which the clinician applies pressure to break for 1 to 2 seconds. The clinician is not trying to break the patient out of the position, but more so check to see that the nerve supply of that muscle is able to fire and keep the muscle contracted. Myotomes allow the clinician to assess the patient's ability to contract and hold the contraction against the force. Inability of the patient to do so means that the nerve root supplies the muscle with synapses to fire is not firing as it should. For the deep tendon reflex of the biceps, the patient's arm is laying in the arms of the clinician while the tendon of the biceps is struck. The clinician strikes the tendon of the biceps while the patient is relaxed, and the striking of the tendon should have a biceps contraction. The purpose of this is to assure that the deep tendon reflex of the patient is functioning as it should based upon the neurological distribution to the reflex. For the brachioradialis deep tendon reflex, the clinician strikes the tuberosity found on the radius where the muscle attaches. The patient should have a slight movement of the hand and the fingers when the spot is struck to result in a reflex. The purpose of this test is to assure that the deep tendon reflex of the patient is functioning as it should based upon the neurological distribution to the reflex. The clinician strikes the distal triceps tendon and the patient should have a reflex in which the elbow extends. The purpose of testing this reflex is to assure that the deep tendon reflex of the patient is functioning as it should be based upon neurological distribution to the reflex. The Valsalva maneuver is done by having the patient simulate a bowel movement so that the intrathecal pressure is increased. This test is done to increase the intrathecal pressure, in which identifies a disc injury because of the pressure. This test increases symptoms that the athlete is experiencing and makes the disc injury. This test is meant to increase this patient's symptoms. The significance of this test is to identify damage to the cervical nerve root by compressing where it originates. Patients experience increased symptoms with this test if they are injured. The clinician applies a downward force while the patient's head is in a position where the nerve roots are compromised. The downward force increases symptoms in the patients with a nerve root dysfunction. Clinically, this allows an athletic trainer to evaluate compromised nerve roots by decreasing the amount of space the nerve passes through. Traction is applied to relieve the symptoms the patient is experiencing. The distraction force should feel good to the athlete because it is opening the space that is compressed or compromised. This test allows for the clinician to add some relief to the patient and identify that a cervical nerve root is being compressed. Once the patient completes the movement, the clinician is then looking to see if the pulse has disappeared. A positive test is indicated by a reproduction of TOS symptoms, including discomfort, numbness, and tingling. The Allen test for thoracic outlook syndrome. Once the patient completes the movement, the clinician is then looking to see if the pulse has disappeared. A positive result is indicated by a reproduction of TOS symptoms, including discomfort, numbness, and tingling. And the clinician is looking for any drop of one of the limbs. A positive result is indicated by a reproduction of TOS symptoms, including discomfort, numbness, and tingling, and a sudden drop of one limb. Once the patient completes the movement, the clinician is then looking to see if the pulse has disappeared. A positive result is indicated by the reproduction of TOS symptoms, including numbness, tingling, and discomfort. AC traction is a test performed by when pulling down on the humerus, you are feeling and looking for separation from the AC joint. This is not to be confused with the sulcus sign test. A positive result of this test is the humerus moving inferior and the scapula indicates a sprain of the AC joint. AC shear is done when the AC joint is compressed. There will be pain in the AC joint or excursion of a clavicle. A positive result of this diagnosis of an AC injury and potentially a coreclavicular ligament. Shoulder salute is a test. The patient would likely feel pain as they were bringing their arm across their body. The positive test would lead to a diagnosis of an AC injury and potentially an impingement injury. This test is done to identify anterior instability after subluxation or dislocation. This test is done by looking for the expression on the patient's face to sense apprehension. This test allows for the clinician to assess instability of the joint and pain for the patient. This test determines the results based on the amount of excessive translation that occurs at the shoulder. A positive test leads to a diagnosis of multidirectional instability and humeral head translation. This test determines if it's positive based on the amount of translation of the humerus anteriorly. A positive test leads to a diagnosis of anterior instability. Norwood and posterior glide are done with the patient in a supine position and the shoulder is at 90 degrees and the arm is in slight horizontal abduction. Overpressure is applied at the elbow. Once overpressure is applied, the clinician is looking to feel if the humeral head slides back excessively. A positive test leads to a diagnosis of posterior instability. And the clinician is looking for the humerus to move away from the glenohumeral joint. A positive test leads to diagnosis of multidirectional instability of the glenohumeral joint. A positive test would be indicated by pain in the subacromial region. This test is used to identify the presence of impingement in the glenohumeral joint by forcing the rotator cuff muscle tendons against the anterior acromion. A positive test would be indicated by pain in the subacromial space, either at the end range of internal rotation or along the course of movement. This test forces the rotator cuff tendons under the coracoacromial arc and against the coracoid process to recreate the symptoms of impingement. This test is found to be positive if pain is found at the end range of horizontal adduction or during the movement of the anterior shoulder. This test is used to locate impingement of the rotator cuff against the coracoacromial arc. Reproduction of the anterior shoulder pain with the evaluation of elbow constitutes a positive test. This test is used to identify subacromial impingement of the rotator cuff against the coracoacromial arc. Empty can is done with the patient's arm at 90 degrees of shoulder flexion in front of the body and full internal rotation of the limb. Pressure is applied to stress the rotator cuff muscles. The clinician applies pressure to the lower end of the arm while it is in position, and symptoms may increase if rotator cuff muscles are injured, supraspinatus to be exact. This test allows for the clinician to make the muscles activate and hold a position to see the ability of the muscle to maintain joint position against pressure. A positive test will present with the patient's inability to remove their hand from their back, indicating a tear in the subscapular muscle. The test is used to identify a tear of the subscapularis tendon and can be observed if the wrist flexes during internal rotation of the shoulder. A positive test is found when the patient cannot apply the external force or even hold the arm in external rotation. This is found when the infraspinatus muscle is compromised. This special test allows a clinician to assess rotator cuff muscle weakness and damage. If a rotator cuff muscle is damaged, the patient will be unable to perform the test, in which a bilateral drop will happen. SPEEDS is a test done to assess the ability of the biceps tendon to withhold overpressure. The significance of this test is that if the patient has a biceps tendon pathology, then they will not be able to hold against their resistance and may experience recreation of pain. This test is used to identify biceps long head tendon pathology, and pain will be felt along the anterior shoulder in the bicipital groove if the test is positive. This deformity means that the patient has torn the long head of the biceps tendon. This test is used to determine the presence of biceps tendinitis. A positive test is indicated by pain along the bicipital groove, or a clicking or popping feeling or sound of the subluxation of the tendon. This test is used to identify biceps tendon pathology if there is pain over the biceps tendon in the bicipital groove. This test is used to identify labral pathologies and is indicated by pain or clicking felt by either the patient or the clinician. The clinician provides overpressure. This test is done by applying pressure along the arm. If pain occurs with that, you have the patient externally rotate and the forearm supinates. A positive test suggests the patient has a labral tear. This test is done in a position where the biceps tendon is exposed and stressed from overpronation, applied by the clinician. This test is done to increase symptoms of a patient experiencing biceps tendinitis or a labral issue because of the stretching done to the tendon and where it attaches. This test indicates a patient with injury to the biceps tendon or labrum because of stress put on the tissues. This test allows for the clinician to see sensitivity or symptoms associated with stress to the soft tissues. Biceps load 1 is done with the patient supine with their arm slightly abducted and their elbow at 90 degrees. The clinician is preventing the patient from performing elbow flexion. This test is done to see biceps tendon pathology. Biceps load 2 is done with the patient supine and their arm abducted to 90 degrees, as well as their shoulder flexed at 90 degrees and external rotation. The clinician again prevents the patient from performing flexion, and this is done to identify a biceps tendon pathology. During the circumduction motion, the clinician is looking for crepitus pain and clicking in the shoulder. Those would be a positive sign for the test. A positive test leads to the diagnosis of a glenohumeral labral tear.